This is EHJ Today. I'm here at the annual scientific sessions of the American Heart Association in Chicago 2014, and I'm talking to a legend in cardiology, Dr. Marc Pfeffer, who is the Zhao Professor of Medicine at Brigham and Women's Hospital and Harvard Medical School in Boston. Welcome, Marc.
Thank you, Thomas.
So, Marc, today we will talk a little bit more personal about your career, your life, your contribution to cardiology. How did you choose to become a doctor and a cardiologist in particular?
Well, I consider myself a very fortunate person. I went to liberal arts college to be a teacher. Had a lab experience in turtle heart, which was totally immersion. I met my wife, future wife, and over the turtle heart. And we both loved cardiovascular physiology. And after graduating from college, I then went to graduate school to get a PhD in physiology and biophysics to work on cardiac physiology.
And where was that?
That was at the University of Oklahoma. And then how fortune would have it, Ed Froelich, who still looks after me, was setting up a lab in hypertension, and he had just moved there from the Cleveland Clinic. And Janice became his technician, and I became the postdoc in the lab, and I graduated as his first postdoc, and then she later became his second postdoc. Okay. So it was an amazing time, and we studied hypertension,
right,
and cardiac hypertrophy.
Exactly, yeah, I remember that, yeah, excellent. And then?
Well, the doctrine at the time was all the work of Professor Braunwald was cardiac contractility. If you remember those days, DPDT. 16 different DPDT over T, DPDT over T over 40, all the indices of contractility. And Professor Froelich was saying, we know hypertrophy is bad. These rats have hypertrophy. Show us their impaired performance and you'll get your PhD. And we did all the studies, acceleration of flow. It was very exciting, filling pressures, cardiac output, and they had preserved function. They didn't have heart failure, right, or didn't have impaired contractility. And I presented this at a national meeting, and it was one of these seminars. It was just the basic work. And this distinguished man came up to me after and said, it's not quite what we've been finding. And this is before the internet. Of course, I knew the man's name, but I didn't know his face, and it was Professor Braunwald. Okay. And we were talking about mechanisms and hypertrophy and the difference between slow development in the genetic hypertensive rat versus the banding, and the conversation went on, and he invited me to Boston. And by this time, I'm in medical school, and we started making music together. And what I've come to understand was he wanted my wife to work in his lab, and the only way to get her was to offer me an internship. All right. So we went to Boston together. We brought our rats, and it was just a new chapter in our lives.
And then you changed gears a little bit from hypertension more to infarction, right?
Which is something I would tell young people. Get an expertise in a certain area, but then make a bridge. So the Braunwald labs were looking at infarct size reduction, which is the minutes, the hours. Right. And what we were doing in hypertension was changes in the heart function over the lifetime of the animals. Right. So we brought that concept of long-term changes after an infarct to the acute stuff that was already going on. So we had our own little part, and we found some very interesting things, that the infarct isn't over in a few days.
And that led to the concept of remodeling.
Exactly, and I have to give my late wife the credit for that, where she was saying, let's look long term. Right. And there it was, that even after the infarct is histologically healed, and that was so amazing. Yeah. Fibrous tissue is there.
Most people would stop.
It's over, and it wasn't. Yeah, it wasn't. And that explained a lot of what the epidemiology was showing. Having an infarct is bad, but it's bad in the long term. So we really got excited about that, and that was the beginning.
And then, of course, you wanted to change that.
Of course, and everyone asks, why did you use ACE inhibitors? Well, our work in Oklahoma said the new compounds, they were new at the time.
Yes.
It was
This
a
was
SWIP
around
compound. This was the 70s, and it was SQ, I forgot the number, for captopril.
Yes, exactly.
And it was so effective in the spontaneously hypertensive rat in preventing hypertrophy and deterioration of function, we just applied it to the infarct, and there it was.
Yes.
Rats could be made to have less damage over time, less adverse changes, and live longer. Now, jumping to man was the next step.
Yes, and that was at the time not so common that you would actually take a concept and then immediately go to the clinic, but you did.
Well, and there again, I'm blessed. I'm in an environment with colleagues that could support you. I've seen other places where if you're doing something, it's snuff you out. But the Brigham, and it was the Peter Bent Brigham at this time, very exciting place, and the people in the cath lab embraced this. Let's try it, let's try it. And we did a small placebo-controlled trial of 50-something people who had an anterior infarct, and the concept in the animal applied. Now, that's all we had. And then, with a lot of help from a lot of people, we did a multinational study called SAVE.
Right, right. And that was really a major contribution, wasn't it? So.
Oh, it was so much fun. You know, now trials are 40 countries. This was just the United States and Canada. 40 sites. We
How
got
many
to
patients?
know 2,231 wonderful volunteering human beings who all had an infarct, who all had a low ejection fraction, but did not have signs and symptoms of heart failure.
Right.
So this was treating.
Like left ventricular dysfunction.
That was the beginning. And by the way, we were bold enough to call it by mechanism, survival and ventricular enlargement. The name captopril wasn't there.
Yes.
And when it was over, it was correct. More people who enlarged did poorly than the people who didn't enlarge, and captopril changed the balance.
Yes.
I like to say it didn't make people immortal, but it changed the balance, lowered the risk.
Yeah, and today it's part of every practice, isn't it?
Well, what's more interesting to me is this concept of remodeling now is if anybody has a new experimental medication, they're going to test it in models to see if they can prevent some of this remodeling. So this thing that my late wife started in this little lab is what people are doing. They don't even know why. But so I get a kick out of that if you can do that, then you're showing a favorable effect on biology. Now, whether it works or not, it's a first step.
And so what are you doing today?
Well, I'm happily remarried after her death and chasing my new wife. And I'm still involved in leadership roles in clinical trials, which I love. I mean, where else can you meet people all around the world with a common objective to see if we can make an improvement in medicine? And this is where I would say to the young people, there's a lot to do implementing today's therapies. We're not perfect, and we can do better. But if we just stop there, then in 10 years we'll still be doing the same thing. And the excitement, the bar is very high to really have an improvement. But we must keep trying. We must keep trying. And the randomized clinical trial is our tool. It's the tool we have to look at benefits and risks.
And where you feel that there is the biggest need today in terms of breakthroughs and improvements in cardiovascular medicine? Of course.
I don't feel like I can own this, but I think everyone has to look at the disease that they're doing. And I tell people who train in medicine, you have the advantage over the PhD. You know the problem.
Exactly.
Figure out what we're hitting our head against the wall, define the problem, and then make a little inroad in it.
Yes. But now in heart failure, the heart failure with preserved ejection fraction is still a bit of an enigma. Do you think that this is an area where new trials would bring some benefit to the patients?
So what we're learning there is the frustration that we don't have our arms around this problem yet.
Yes.
And it's many different things. And I think after TopCat, after looking at the echoes, We just have to figure out the subpopulations that have the greatest risk. Maybe different therapies will have a differential effect. But it's pretty exciting. So we're in the ground floor. So if somebody wants to start here, there's not a lot behind you. You're on the ground floor. We all have to get into this and figure out who these people are and how we can help them.
So there's enough for young people to make their career like you did.
Certainly.
Thank you very much,
Okay, thank
Marc.
you, Thomas.
It was a pleasure.